Now, moving on to the most common type of fractures which are present in the children, that is the supracondylar fractures in children. In this section, we will be discussing the mechanism of injury and their pathoanatomy, clinical features, its treatment, and what are the complications associated with the supracondylar fractures. Now, coming to the supracondylar fractures, most common fractures in the children, and distal fragment is displaced either posteriorly or anteriorly, and that is actually how they are classified as well. Now, coming to the mechanism injury, the most common form of the injury is usually actually such that the patient fall on the usually results in the fall on the outstretched hand. If the fall is on the outstretched hand, the elbow will be in extension. This would result in usually the posterior displacement of the fracture, which is in the case of the 95% of the cases, and it's called as extension type of injury. Almost 95 to 97% of the cases are in this extension type of injury or hyperextension injury. This is due to the fall on the outstretched hand and humerus breaks usually just above the condyles, leading to supracondylar extension type injury. Other cause is in 2 to 3% of the cases, or in some books, according to some books, is 3 to 5% of the cases. The fall is actually the distal fragment pushed backwards in such a way that the fall of the children is actually on the flexed elbow. In this, the distal fragment will actually move anteriorly and jagged up and pokes into the soft tissues. Injury to this is the kind of injury in which the brachial injury artery can be damaged as well, or the median nerve can also get damaged most of the time. This is usually a flexion type injury in which it can be an open fracture as well. This leads to anterior displacement, which is very rare, but this is due to direct violence or fall on the flexed elbow. And when the joint is in a flexion, this can result in this, the distal fragment is actually poking anteriorly into it. Now, coming to the classification, there is a Gartland classification, and actually which has been modified by multiple times as well by many authors, but mainly the Gartland classification started with 3 specific type 1, 2, 3, which has been modified into a type 4 injury as well. Type 1 is an undisplaced fracture, supracondylar fracture. Type 2 is angulated fracture with the posterior cortex intact. Actually, the posterior cortex is hinged in such a way. Could this be 2A type, which is less severe and distal fragment merely angulated? 2B is severe injury and fragment is not only angulated but also malrotated over the hinge. Type 3 is a completely displaced fracture. This was the original Gartland classification, which was later on modified by many authors. And now there is a type 4 injury as well, in which this is an anteriorly displaced fracture, which is a flexion type injury, which is around the elbow. Coming to the clinical features. Patient usually comes with the pain and elbow is swollen, and patient usually has a history of either fall on the outstretched hand or fall on the flexed elbow. S-type deformity, if you see it, subtle S is actually seen usually around the elbow if there's a closed injury. Bony landmarks are abnormal, that is the triangle formed by the both the median and lateral condyle, the humerus and olecranon is actually disrupted. Concern regarding ischemia sometimes present, especially if it's an anterior displacement leading to brachial artery injury as well. And sometimes the pain-free extension of the flexor muscles is actually not possible as well. If you ask the child to move the arm, he or she will not be able to move the arm, and moving the arm passively would result in a lot of pain as well. You need to assess the neurovascular status, whether it is radial artery and ulnar artery is palpable or not, and this mainly the median, ulnar and radial nerve can be assessed as well. Now, coming to the x-rays, and we are suspecting a supracondylar fracture, we have to get an x-rays as well. Fracture mostly usually clear in the lateral view. If you see it over here in the AP view, if you see closely as in the children, you have to see very for the subtle changes as well. This is the fracture line with a low fracture which is going right over here. And on the lateral view, similarly, anterior humeral line is also disrupted, and the fragment, distal fragment, is moved slightly posteriorly, and anterior humeral line is not passing through the anterior 2/3 of the capitellum. Therefore, this is there will be some degree of anterior displacement, and this means that there is definitely some supracondylar fracture is present, especially in the case of undisplaced fracture. Usually, sometimes even the anterior humeral line is normal, undisplaced fracture, then you have to look at the posterior fat pad sign, which is due to the accumulation of hematoma over here. And posterior fat pad sign, a sale sign is suspicious, and usually denotes there is an underlying hematoma that will be due to some kind of undisplaced fracture most of the time. Therefore, we have to look at, then come the posterior displaced fracture. Usually in the fracture line is obliquely downwards and forwards, and distal fragments usually tilted backwards, as you can appreciate it over here. Now coming to the anteriorly displaced fracture. In that case, the fracture line runs downwards and backwards, distal fragments is angulated forwards, and usually rarely it is a normal X-ray, but if it's line drawn along the anterior cortex of the humerus, that is the anterior humeral line, should cross the middle of the capitulum. If you were seeing this X-ray, this is the anterior humeral line, and this is not going through the anterior capitulum. If in a normal X-ray, this anterior humeral line will cross right from here. And this is an indication. You have to see what is the ulnar humeral radiocapitellar line is called as. This is the radius and this is the capitulum. Radiocapitellar line is intact. This means there is no angulation. But anterior humeral line, if not going through the middle of the capitulum, or at least through the anterior 2/3 of the capitulum, this means there is some subtle fracture. You need to look it out. It may be undisplaced. But then you have to look at the posterior fat sign as well most of the time, if it's a normal X-ray. Other option is if the line is anterior to the capitulum, it is a type 2 fracture. Even if it's not displaced, it will be 2A type, or it could be type 2B fracture. Now if you see this X-ray, now in this X-ray the fracture line is very clearly possible. What else you look for? Radiocapitellar line is okay, but there is a fracture line over the AP view. If you see on the lateral view, this is the anterior humeral line, which is going, and it's going posterior to the capitulum. This means this is an extension type injury along with a type 2 fracture. Now coming to the anterior view, it sometimes is difficult to obtain but without causing pain, but we have to give an AP and lateral view and look at the distal fragment which translated or angulated sideways. Sometimes this could be present going this way or that way as well. Distal fragment usually rotated, and sometimes if you see this on the lateral view, then you can appreciate it properly. It's not translated, but it's angulated or it's rotated over its axis, and that is why you see this instead of having over here, it's actually right posteriorly. Then sometimes on AP view you have to measure the Bowman's angle as well, especially if it's translated. Marked increase or decrease, normally it's 9 to 26. If it's below that or more than that, usually there will be marked changes in the Bowman angle. How we calculate the Bowman angle? There are actually two different ways out of it as well. Some minus it from 90 to make it between 9 and 26, and according to other books it's between more than 70 degrees. Now coming to the treatment, depending upon the type of fracture, if it's type 1 fracture that is undisplaced or there is a suspicion of fracture, then we can manage it with splint in 30 degrees of flexion and maintain it for 2 weeks and get a repeat X-ray at almost 10 to 14 days to prevent neurovascular injury at times. And during X-ray examination, most of the time we have to be very careful not to over exacerbate the injury in form of displacement. If it is a type 1 undisplaced fracture, in that case, the anterior humeral line is passing through the capitulum, as can be viewed on this X-rays. And if you see it over here, on AP view, you can appreciate a fracture. On lateral view, you can appreciate a fracture, but anterior humeral line is passing through the center of the capitulum. This means although there is a supracondylar fracture, but it's undisplaced. In that, the treatment is elbow mobilization at 90 degrees, lightweight cast or splint, but usually a sling can also be used as well. And that splint remains for 3 weeks, and after that splint is removed, X-rays are done, and gradual range of mobilization is at the elbow, range of motion is started. If it's a type 2A fracture, in which if this happens is that anteriorly the cortex is displaced, but posteriorly it's hinged over the periosteum. And in 2B, this fragment not only is actually translated, it rotates on its axis as well. Then our method is actually to go for reduction. Reduction is actually done under general anesthesia, and we try to convert this type 2 injury into type 1, so that if we can convert it to type 1, then probably we will not have to operate this. But what stepwise maneuver has to be followed. The first is the traction for 2 to 3 minutes along the axis of the arm to counter the actually above elbow, then correction sideways tilt shift. If the distal fragment translated medial laterally, then that can be corrected as well. Then is the gradual flexion of the elbow to 120 degrees. First you apply traction, then you adjust medial lateral translation, then you flex the elbow to 120 degrees, and then you lastly pronate the arm. Pronation of the arm would actually lock this reduced fragment into its place, and it will not actually get dislocated again or translated again. And then feel the pulse and check the capillary return. Why we need to do that? Because we need to make it sure that this maneuver has not resulted in damage to the arteria in form of brachial artery. Now coming to type 2A injury, as I told you, in which there is a posteriorly hinged as well. You need to reduce it back and confirm it on the AP and lateral view, and that is usually done in form of fluoroscope right in the theater when we are doing this maneuver. If Baumann angle is assessed on true AP view, subtle medial tilt and rotation is recognized, and then if we still suspect it's not a 2A, it's a type 2B injury, we go for K-wire fixation, and configuration of wires can vary. It could be, there's multiple options. This could be 2 lateral wires, or it could be 2 lateral and 1 medial wire, or it could be cross wires in form of 1 lateral and 1 medial wire. Then the different configurations, actually nowadays it's agreed to whatever configuration is good, you can use it, although medial wire is actually associated with ulnar nerve injury. Then other option is medial mini approach. It's actually safest for placing the medial wire. Why we need to avoid it actually? Because we have to be very sure that our K wire, which is going through the medial condyle, is not actually damaging the ulnar nerve. And back slab should be applied, and usually it's usually kept for 3 to 4 weeks. At 4 weeks, we take out of the back slab, get the check x-rays, and then remove the wires as well. And after that, usually the range of motion is started. Arm is held in a collar and cuff, circulation is checked, and x-rays obtained in 3 to 5 days for the redisplacement, and then splint can be retained for 3 to 4 weeks. You remove the splint at 3 weeks, you remove the K wires, keep the splint for 4 weeks, at 1 more week, and once at 4 weeks, then remove the splint and start the range of motion. Now coming to type 2B and 3 fractures. Why? Type 3 are those in which there is completely displaced, or type 2B are in which there is actually the hinge is there posteriorly, but the distal fragment is actually rotated on its axis. In this, if this is a type 3 in complete displacement fracture, if you see the anterior humeral line is way beyond anteriorly into the capitellum, it has to be reduced under general anesthesia, and the option is CRIF, close reduction internal fixation with percutaneous pin. If we are not able to reduce it with or hold it with K wires, then probably we have to go for open reduction internal fixation with K wires. But that has to be done for both the 2B and 3 type fractures. Usually associated with severe swelling and difficulty to reduce the fracture, but usually it can be reduced as well. By the same maneuver, that is the first the traction, then adjust the translation of the distal fragment, then give a flexion, and lastly pronate the arm. Now coming to the open adduction. Although rarely done nowadays with the fluoroscope readily available in most centers, but if we are not able to reduce it closely, or if the fracture still remains displaced, then probably we have to go for open adduction internal fixation if the fracture is not reduced, or it's an open fracture, or if it's associated with a vascular injury. If already a brachial injury artery is injured, then we have to go for open adduction internal fixation via anterior approach to first repair the artery as well as fix the bones as well. Hematoma is evacuated, fracture is reduced and held by the 2 K wires, but we have to see whether, and then on x-rays we have to check for elbow stability as well. And if this fracture fragments are unstable, we can go for 3rd K wire, but usually it's not always needed. Now coming to the continuous traction. Continuous traction is a technique in which actually a screw through the olecranon is first passed, and arm is held in overhead so that actually the weight of the body helps to reduce it gradually, but usually nowadays done, because we can apply the traction on the operating table and reduce it. But if it's not reducing despite all the maneuvers, and this is can be used, and once the fracture reduces itself, then we can check for neurovascular injury. If it's not associated with any neurovascular injury, then all we can do is then pass the 2K wires so that it reduces the holds these K wires hold the fracture fragment in place for 3 to 4 weeks. If the fracture is severely displaced and not reduced by manipulation, if pulse is obliterated, image intensification is not available, but that is only we can use this indication for continuous traction, or for a severe open or multiple injuries. It's already multiple comminuted fracture, it's open fracture, we have to go for open reduction fixation. Then we can pass the screw, hold the arm above, and let the gravity do the reduction. And once the gravity has done the reduction, we can pass 2K wires to the supracondylar fracture. Now coming to that fourth type, that is an interiorly displaced fracture, especially in the elbow flexion type injury. If you see it over here, this is the lateral view, this is the AP view, and this is the lateral view. In AP view, you can appreciate there's a supracondylar fracture where the distal humerus morely going towards medially, as well as rotated over it as well. Now this is a classical flexion type injury, and what happens is, if it was an extension type injury, it was reduced by closed maneuver by flexion. Flexion type anterior type injury will not be reduced by flexion type, but rather will a different maneuver. First we have to reduce by pulling on the forearm, that is the applied traction. Then with elbows semi-flex, not flex up to 120 degrees, apply a thumb pressure over the fragment, distal fragment. We have to reduce the translation, and then extend the elbow properly, so that the fracture fragment, which was actually going anteriorly, has been reduced back to its posterior location. And then once the close reduction is be done, we can pass the 2K wires, one medial, one lateral, or two lateral, as per surgeon's preference, so that these K wires hold the fracture fragment in place for 3 to 4 weeks. Now coming to the complications which may be associated. Early complications are actually when we are operating, could be a vascular injury or could be nerve injury, especially the ulnar nerve, which could be damaged when we are passing the medial pin. The late classification includes malunion, elbow stiffness, or heterotopic ossification as well, most of the time. In this, we have briefly discussed supracondylar fractures. It is one of the most common fractures in the children. Usually the fall of the mechanism is such that 97% of the cases is an extension type injury, which happens due to the fall on the outstretched hand. 2 to 3% of the cases due to fall on the flexed elbow, this could be a flexion type injury as well. Most of there's a Gartland classification, which is actually type 1, 2, and 3, which was modified by the different authors for accommodating a flexion type injury as well. Type 1 is non-displaced fracture. Type 2 is minimally displaced, with the posterior cortex is hinged with periosteum. Type 2A, in which it's not rotated, and type 2B, it rotates on its axis. Type 3 is completely displaced fracture. Type 4 was actually later on added to accommodate for a flexion type interior displacement of the distal fragment, which can happen with a flexion type injury. The most common mechanism is first the close reduction, and in case of type 1, we can go for conservative management as well, close reduction and immobilization in form of a cast for 3 to 4 weeks. If it's type 2 or 2A or type injury, usually in that case we have to go for a close reduction and internal fixation with 2 K wires, which could be either 2 lateral and 1 medial, 1 lateral pin. If it's type 3, similarly we have to reduce it closely and go for close reduction internal fixation. But for any reason, if we are unable to reduce it closely or close reduction fails, then we have to go for open reduction internal fixation and fix this supracondylar fracture with 2 K wires. Thank you very much. Keep watching sqadia.com.